consisting of increased fibrosis and adventitial bursal tissue. Fat pad abnormalities in the hindfoot are difficult problems. I generally start with fat-containing orthoses, again with variable success. In this companion case, this patient presented with symptoms consistent with proximal plantar fasciopathy. As a general rule, the plantar fat pad should compress less than 50% under transducer pressure. The long axis image on the left reveals hypoechoic thickening of the proximal central cord of the plantar fascia, a typical finding in proximal plantar fasciopathy. However, the cine clip on the right, obtained during dynamic compression, shows a fractured and insufficient fat pad. In these cases, it is often unclear whether the primary pain generator is the central cord, the fat pad, or a combination of both. Another important structure to assess in the plantar fascia protocol is the lateral cord of the plantar fascia. As discussed earlier, the lateral cord shares a common origin with the central cord on the medial tubercle of the calcaneus. It traverses distally along the superficial border of the abductor digiti minimi muscle before inserting onto the base of the fifth metatarsal bone. Compared to the insertion of the peroneus brevis tendon, the lateral cord of the plantar fascia has a much broader attachment footprint. As an aside, the lateral cord of the plantar fascia is likely the primary contributor to an avulsion fracture at the base of the fifth metatarsal rather than the peroneus brevis tendon. The long and short axis ultrasound images demonstrate the insertional footprint of the lateral cord of the plantar fascia onto the fifth metatarsal, as well as the attachment of the peroneus brevis tendon, highlighting their distinct anatomical relationships. Enthesiopathy of the lateral cord of the plantar fascia can occur in isolation or in combination with plantar fasciopathy. Because the central cord is a relatively medial structure, patients with plantar fasciopathy will often shift their weight laterally, predisposing them to concurrent lateral cord of the plantar fascia enthesiopathy. Ultrasound findings of lateral cord enthesiopathy include hypoechoic thickening, with or without increased vascularity, and partial thickness tearing. Additionally, cortical irregularity may be present at the insertional footprint of the lateral cord. However, these changes can also be asymptomatic, making it important to correlate ultrasound findings with sonopalpatory pain. Treatment of lateral cord of the plantar fascia enthesiopathy begins with addressing plantar fasciopathy if it is present. If both plantar fasciopathy and enthesiopathy of the lateral cord are